In this episode of Quick Hits, we're excited to host Dr. Julia Skapik, the CMIO of the National Association of Community Health Centers and board chair of the International Board of Directors for HL7. With her extensive background as a practicing physician and her expertise in public health policy, along with her work with community health centers, Dr. Skapik brings knowledge, experience, and passion to the table. Her career has been dedicated to integrating technology and data to address social determinants of health, aiming to bridge gaps in care and promote equity across healthcare systems. Today, she will share lessons from her journey and discuss the important role that equity plays in shaping the future of healthcare. Tune in as Dr. Skapik helps us gain a better understanding of how social determinants of health can lead to transformative health outcomes and a more inclusive approach to medical practice.
Welcome to another episode of Quick Hits. I'm your host, Ken Booth, joined as always by Tyler Smith. Tyler, how are you?
Excited to be here, Ken.
Good. Yeah, me too. We've got a great guest this episode. We're talking to Dr. Julia Skapik. She's the Chief Medical Information Officer at the National Association of Community Health Centers. Dr. Skapik, welcome to the show.
Thank you so much for having me.
We thought first it'd be nice to just get a rundown of your background if we could.
Julia Skapik. I'm a physician and clinical informaticist. Ken mentioned I'm with the CMIO at the National Association of Community Health Centers, which means that I do a lot of public health, research, quality improvement work in community health centers around the country, trying to support their technology and data applications and use. I came to health IT through work with the federal government, the National Science Foundation, the Office of the National Coordinator for Health IT. I am a practicing physician in internal medicine, and I see patients part-time at a community health center in Northern Virginia called Neighborhood Health of Virginia. And I do occasional moonlighting as a hospitalist in the Inova Health System. I'm also the chair of the board of HL7 International, meaning that I do a lot of standards development work and advocacy in health information technology.
Well, you are quite busy. That's an impressive resume. I guess a question. So since you come from that clinical background, what initially attracted you to healthcare IT?
Yeah, so as a medical student, I was really interested in the problem of medical errors and quality. And Peter Pronovost, who's a leader in this area and was a mentor of mine, likes to present this as a Swiss cheese model, which is that the problem is not that people are bad. We know people will make mistakes. But if we build systems that allow those mistakes to reach the patient, then that's our collective fault because we built those systems thusly. And I see that exact same analogy in the use of technology and data in healthcare. We can't expect people to overcome limitations of our technology and data use. And so I see this as a systems problem that we need to tackle from a high level and an on the ground level with a constant sort of level of attention to human-centered design and usability. I think we still fail to focus on that, but we also fail to really measure the impact of not using the information available to us, of making work harder or less logical, if you will, and of putting those technology and data tasks in between the care team and the patient.
Would you say that you also touch different points when it comes to health equity?
Yeah, absolutely. I mean, I think technology can enable or really exacerbate inequity. Um,
Hmm.
but it also could be a driver to reduce equity. We could make it easier for people to reach out. We could make it easier for people to access services. We could use more languages. We could use more accessibility. We could visualize things that in the past were really difficult to sort of explain verbally. And so the potential is just outstanding. But the way that we've been doing it is probably making a lot of problems worse and not better. And I think that extends to burnout that care teams experience, but it also extends to continually failing to meet patient and user needs. And there's no way to address equity if we can't sort of wrap our arms around the needs of everyone and meet those people in an equitable way.
Can you elaborate a little bit on what you think is leading to that burnout? What are some of the trends that you're seeing that are leading to increasing inequity and increasing provider burnout?
So I think rightfully so, many care team members feel that they've become sort of glorified data entry clerks. And I think that that's a reasonable impression to get at the end of a day in which you perceived a lot of the things you did, information you entered, would never be used. That a lot of the clicks you did didn't actually add anything to the care processes. And where your attention that was spent on figuring out where the information is and how to execute the tasks that you want um, took away from your looking at the patient, listening to the patient, interacting with the patient, and importantly also thinking about the patient's problems. Because if people are multitasking, and I'm doing this most of the time when I'm interacting with patients in the clinic, I'm both trying to interact with the EHR and trying to interact with the patient. So all of my attention, by definition, is not focused on talking to and thinking about the patient.
What would make it easier for you to either A, focus on the patient, or I guess do a better job of multitasking?
Yeah, I think there's a big explosion in AI enabled documentation, but the documentation AI tools are definitely an emerging area and one which I think people are actually finding them to be usable and having some satisfaction in taking some of those documentation tasks off their hands.
Do you find that there's a challenge for community health centers to have access to the newest or latest in technology, or are there enough government grants providing access to that?
Yeah, actually, we have a big problem in healthcare of how to pay for infrastructure and ongoing costs. And that's true even at large, very well resourced organizations, in addition to smaller, lower resource ones. The problem, though, is more burdensome at the low resourced organization level. Health centers work on very small margins. They generally provide outpatient care for patients at about a quarter of the cost of a traditional outpatient setting. So the line in the budget for the people who understand how to vet different options to deploy those in a connected way with the systems that are already in place to do the testing. Those things are much harder for health centers because they just don't have the slack and the people and the knowledge sometimes to be able to execute those. And while I think all health centers find a way eventually to figure these kinds of things out, them having a lag of 3 to 5 years on a lot of these technology opportunities is gonna impact, the value they can provide and the time it takes for them really to make that available to their patients. But there's not really grant funds to help organizations do this, so you have to make a value judgment on, can I save money somewhere so that I can afford to pay for this? I think some tools are much better lend themselves to an obvious return on investment. The documentation tools are probably one of those areas that are easier to make the argument, and some of them are relatively inexpensive. But we could talk about a lot of other kinds of technology tools, things that help you to visualize information, things that interact with patients. And in equity settings, those are challenging in part because patients in health centers have a lot more literacy barriers. That's sometimes because they have a primary language other than English, but it also could be related to cognitive impairment, lower educational attainment, and ongoing issues about sort of cultural representativeness and the language being used in those materials. And then there's an added burden of access, right? If you don't have a smartphone, you only have a flip phone, you can basically only interact with texting. You won't be able to enter a patient portal. You won't be able to do a telemedicine visit. If you don't have access to broadband because you live in a rural area or you live in a broadband sort of a low spot, that will also impact your ability to utilize things like remote patient monitoring and telehealth.
Yeah, it's hard to believe that, in 2024, there are still areas where people just don't have access to broadband. It just really shows the infrastructure upgrades that are needed kind of countrywide.
Yeah, and sometimes that access is not that they couldn't get it, but that they can't afford that. That would be like paying for medicines or food versus paying for the internet, and people have to make those decisions.
Dr. Skapik, when we look at your career, it's pretty cool because you started med school like in what, Web 2.0,
Mhm.
and you've been around not only for the internet blossoming during your professional career, but also, you were at ONC around, I guess, the meaningful use carrot days, if you will, before the stick days. And this conversation really highlights how much further we still all have to go in terms of technology adoption and just widespread usage. But in terms of what's been adopted or what has been leveraged well over your practicing of medicine and being in this space, what stands out to you?
Yeah, I mean, I think that right now we're in a really exciting place because we have laid the groundwork for a lot of vision of the future as it might look more like smartphones and the web than the traditional sort of landed in a box healthcare EHR kind of space. That being said, I think from a user perspective, not a ton has changed in the last, 10 plus years since I started at ONC. And even really, not a lot has changed in the last 20 years in that space to some extent. We're getting more sort of bells and whistles, a little more functionality, but I think there's a space to kind of, start blowing some pieces up and say, why do we use this method of looking at lab values? What could we do to visualize those? Could we make them 3D? Could we represent them using colors and uh, annotations? And could we generate, uh, decision support places to engage the user and, oh, that's a big change. I should look at that change. Tell me about that change. Right now, those things are sort of left to the person to interpret on their own. And a person who's sort of information overload and doing multiple tasks has an easy time missing some of those signals as they are presented to us. I think similarly, the move to have team-based care is also really exciting right now because the EHR is still largely sort of document based. A single person usually creates a single record, and then that results in multiple people making very similar sort of versions of that. If we were to use AI and technology to integrate all of those pieces into a single view, everyone would be sort of seeing the same patient in the same way, as opposed to seeing them as their kidneys or as their skin or as their
Mm.
depression. That's
Mm.
I think, a really important piece of patient-centered care is if it's easy to sort of lop off a piece of the patient and think about it separately, then we forgot the rest of that patient, and we might fail to sort of understand them in the context that they come to us in.
So we need to bring more humanity to the technology and a better user experience overall.
Yeah, and while I'm a huge proponent of structured data, because machines need to be able to do most of this work and unstructured data can make that challenging, I think we do need to do more to let the patient say things in their own words and show that to people involved in their care. Because if the patient can't have their own stated goal about their health be part of that conversation, then the agenda is always going to be designed by the person's agenda who's sitting in front of that record and that patient. So it'll go back to the kidneys when maybe the patient has some other things that are important to them as well that should be considerations as we make decisions, hopefully together and not just one sided.
That's a great segue. Speaking of structured data, and luckily Ken is an actual engineer, so the two of you all can nerd out much more than I'm capable of. But curious in your work in HL7, how you bring the physician's lens to that committee, and maybe if you can just talk us through some of the things you're excited about that you all have been working on that you're allowed to share.
Yeah, absolutely. So, HL7 is an international standards development organization. We've been around for almost 40 years now, I believe. We're ANSI certified, which means that we follow the the standards development organization rules set forth internationally about how to do consensus-based standards building. And the community is a fun mixture of people who come from engineering backgrounds, people who are clinicians, people who work at large vendors, people who work at payers. So a lot of different roles are represented there. One of the challenges of doing standards work is the standard is sort of the highest level at the top of some sort of hill or mountain. And I think of the standard as sort of like water that kind of flows down the hill until it gets to the bottom where it sort of touches the patient and the care team and the system that is being used to deliver healthcare. There's a really big distance between the top of that mountain and the bottom of it. And if standards are not designed with some of the viewpoints and priorities of those people who are getting the water at the bottom of the hill, then there's going to be a lot of unanticipated challenges and consequences to things that happen way up there at the top. So, a big initiative of HL7 is to expand our work in understanding and engaging implementers. HL7 has a program called Fire Accelerators, and the Fire Accelerators are actually made up of groups of stakeholders that are working together on a use case. Usually, they're multidisciplinary, and oftentimes they come from different sectors of our healthcare ecosystem. The Da Vinci Accelerator, the first one, is led by payers, but a lot of what it does is seek to have all the payers agree on how they would standardize information and then share it between each other, between patients, between providers, between regulatory bodies. And that work is simultaneously being deployed at payers as it's being developed. So it's really informed by how it's getting done and not just by how we think it should be done. Similarly, the Gravity Project is the social determinants or social drivers of health accelerator. There are members from patient advocacy groups, community based organizations, healthcare organizations, the federal government, payers, sort of all around the scope of practice of social care. And that team of folks really helps to sort of bring visibility to the different perspectives that we need to meet as we build the workflows and the content that would actually support the standardized capture of data and sharing of data. And then for me, the most important thing is always the use. If I have a billion petabytes of data, but I'm not doing anything with it, I'm not really getting any value, right? So we need to make sure that the end goal is something that improves the quality of care or the experience for the patient. I'll mention we do have an AI task force at HL7, and we're looking at what standards could exist to help guide people who want to develop and use AI in having trust and transparency and understanding the intent and scope of different algorithms. This can help people to go to a marketplace of AI products and sort of evaluate whether or not they're right for them. We're still learning a lot in AI about how, to what extent, the training of a model and the kinds of information that's present in that training influences its performance in different contexts. And so, um, if we can have insight into what those people are and what that data is, we can have insight into, does that match the patient population we have? And I think there'll be increasingly interesting research in what happens when I take something developed in one context, try to apply it to a new context. We've already seen some articles come out saying that it doesn't really work in a number of examples to try and reuse those things. And I think there is, from the AI industry, a tendency for them to say, "Well, we figured this out. We have this AI tool," um, but not to be able to necessarily demonstrate that that is for everyone, and not necessarily only targeting the people they know it will be good for versus the people they hope it will be good for.
Right. And that's a conversation we've been having quite a bit lately on the podcast. But with AI, like, who do you think is leading the charge in helping the AI engineers, because most of them don't have a medical background? Like, where's the connect there? What efforts are being made there, do you think?
Yeah, I mean, I have a real concern about that just because, we're at the place we are at with many other health technology tools. because of a lack of engagement and multidisciplinary team-based work
Hmm.
on how to design things. And, I believe that it's really important to participate in HL7 so we can make sure all the voices are represented. But I also think from a design perspective of anything, it's important to make sure that all of the stakeholders are represented. And so when people talk about, oh, our tool helps with health equity, then I say, oh, what people who represent health equity groups did you have in the room when you designed your tool? And if the person can't answer that, I think you always need to sort of step back for a minute and think, Ho do I need to get a group of those people and now look at this thing so that we can see whether or not it actually meets those needs? I mean, I think if you get a group of physicians in a room and show them a lot of health IT tools, they can tell you right off the bat if any clinician had a role in the design, and I think most people would sort of scoff at the idea that that's a routine practice in the existing kind of, health IT space just because of, how unintuitive some things seem and how, they don't really seem to match or meet the needs of the user. Like in my EHR, an alert pops up every time I attempt to order a medication, even if I haven't actually ordered one. Maybe I updated the med list, like a long list of quote drug interactions pops up, but it'll include things like you ordered test strips for the patient for with diabetes and you ordered lancets, two things that they must have to do the test. And then it sees that as a duplicate, and then it asks me to click again to say, do I want to do that? And that's just crazy frustrating because I have to do that a
Sure.
lot
Right.
in my work. So
I've been on the receiving end of those criticisms before. It's like, no, it's just an extra button click. But sure enough, oh, well,
those
they have to
yeah,
do it
those clicks add
150
up.
times a day. Yeah, it
They add
adds
up
up.
really fast. But yeah, in terms of, making sure that the future is gonna be different than the past, I think we have to sort of bang on a pot lid or something really loud about the engagement of patients and care teams and the development and the surveillance of this work. And I think it's really critically important that there has to be more accountability for the organizations that own and in many cases make quite a lot of money off of the backs of the healthcare workers who have to pay for those things in being accountable to responding to all of these concerns. Personally, I notice that many organizations have told us at NAC that while they have a mechanism to request for changes and improvements, no one really seems very uh, urgently desiring to meet their needs and to engage with them to understand those needs. And I understand that developers have long lists of backlogs, and there are a lot of regulatory things that they have to maintain. But if you have a hit list of 50 things and usability is always the 50th thing, you will never get to it.
No, that's absolutely true.
When you talk about organizations, another piece of your career that I think would love to shed a little bit more light on, working with FQHCs. At HDM, we've gotten to work with or had the pleasure of working with FQHCs over the past 2 years or so, and it's really, or maybe even the past 4 years, it's really opened my eyes to a way that care can be delivered in the community that feels comfortable for those members of the community, and then still allows with Epic Connect or other methods, still allows the data to get exchanged, so that ideally, we have a robust patient chart and patient population within our urban centers. But just curious as to how you got involved with FQHCs at the onset, and where you see FQHCs evolving over the next 5 to 10 years, if you
Yeah,
will.
so I would encourage anyone who's listening to think about the work that they're doing and think, why haven't I involved community health centers in this work? And if I want to test a tool, is a community health center a good or great partner to help design and test? I think the answer is absolutely yes. I get frustrated sometimes that there's been a lot of excitement the last 5 years or so about SDOH, but almost no one is recognizing the fact that health centers have been tracking social needs and treating them with essential services for now 60 years. The program has been in existence. That has always been a core requirement of FQHCs. So I think this is another case where we're not really asking the experts how to move forward, and we're not really elevating their voices to understand how they've been successful, even with the lack of technology for a lot of that time. The health centers are excited to engage, but they are not excited to have someone tell them what to do. So um, I frequently see researchers come up with a design and a proposal and then try to sort of come to the health center and say, "I want you to do this, and I'll give you some money for that." That's not a that's not a sort of shared design model at all, and that really puts you in a position of not benefiting from all that knowledge and experience about how to engage these patient populations, what their real needs are, and what those outcomes are likely to look like. And so I think, I've even seen in FQHCs people developing their own technology tools, and working with vendors and partners to design research and do all kinds of innovative things. But if they're not invited to that discussion, then we'll continue to have that equity sort of trailing behind us. And not me personally, but also NAC would be excited to help organizations connect with health centers. I think you can also, do some outreach to understand sort of who are the health centers doing work in your space and what are they doing. We NAC tries very hard to lift some of those voices up, but you can just go to like a local or a national paper and find plenty of examples. So those health center patients, the health center, they're there, but usually because they don't have another choice. I've seen a lot of patients, since the pandemic, and I said, well, when was the last time you saw a doctor? And they'll say 7 years ago, sometimes 15 years ago. I think I had someone who said 30 years ago. And I said, "Why didn't you come sooner?" And they said, "Well, I didn't know where to go." And so it's important for us to also tell everyone, there is a point of access through health centers, and that's available to people in every state and territory of the United States. And they'll take anyone regardless of their ability to pay, and with a specific goal of meeting their needs and their background.
Some more community outreach would help in that
Yeah, I think
respect.
that's an ongoing challenge for NAC too.
Where do you see AI going in the next 5 to 10 years? And do you believe in the singularity?
So I'm very excited about AI in that I think this is an opportunity for us to make it good and to make it safe. As I've told many people many times, I think if we're not using AI to improve usability and workflow, then that conversation is sort of God leaves a bad taste in my mouth. But people will use AI for
True.
whatever they want, regardless, right? We're aware of, AI fraud attempts. It's very easy to generate in a number of minutes hundreds of thousands of fake claims and to submit them, and potentially get paid. We already have a big problem with fraud in this country in healthcare. So hopefully, we will be paying attention to the bad actor pieces of AI. But I think most of the negative AI work can just come from lack of knowledge and experience. And so I think it is good that people are paying attention to how important it is to understand and to create rules and to create guidance on how to do this correctly. And I think the documentation tools are sort of in the right place at the right time, right? Large language models have gotten to a place of maturity where they're actually being accurate and understanding language. Now, from an equity perspective, I think a great question is, does an AI tool understand documentation the same way for a person who has a primary language other than English, speaking in English? Because oftentimes those people will construct sentences kind of differently. Um, Also, similarly, does it understand colloquial slang? There's a famous example in medical school about the patient you ask, do they have diabetes? And they say no. And then the attending comes in and goes, oh, I got to talk about your sugar. And they're like, oh, yeah, my sugar, because that's how they contextualize diabetes in their life. So, understanding a lot of those nuances and making sure that those aren't the things that are afterthoughts. Those are the things that are built into sort of the refinement and testing procedures of AI. because some of the early AI tools were really not very successful. I was a user of the Epic sepsis module, and if a patient came in with any kind of alcohol related problem, I knew that that sepsis thing was going to fire because their lactate's going to be a little elevated. Some of their other vital signs are going to be up. The Optum tool that was showing, that was recommending more services for white patients than black patients. And that was because in its training, it failed to understand that there's already a disparity of accessing those services for black patients. So it saw that disparity as something that was built into the model and it reinforced that disparity. So it's really, I know people talk about prompt designers, and I saw, I think, something on John Oliver or John Stewart making fun of that the other day. But it is actually important that we're, going out and aggressively getting people to learn these things and to teach us about them, because this is a good example of something where you're not going to stumble into the right answer. You have to be really smart about how you design and use these things. And we just don't have the body of knowledge. We don't have the number of people to really be there yet. So I think it's a bit of a cautionary tale. But I think if we apply it in ways that we see that the reapplication of a use case designed for something else, because all of this AI stuff was designed to do all sorts of things, right? For reapplying use cases in healthcare use cases that are reasonably approximatable, if that's a thing, and then if we're also involving the people who understand how the healthcare use case is different or has considerations that might not apply to something like buying a new watch. Um, then I think we can probably manage and learn to grow into that space.
Well, Dr. Skapik, we thank you so much for taking the time out of your busy schedule to talk with Tyler and I. And you've really kind of opened our eyes to the importance of health equity. Just a quick thought. What can we do individually to make sure that we are promoting health equity?
Yeah, so, I like to use the phrase equity first. So, regardless of what the problem is that you're about to tackle, to say, who are the people who are likely to have the worst outcome here? Who are the people that have the least resources and ability to marshal to respond to this challenge? And while maybe our primary solution doesn't have all of the aspects of our equity approach incorporated into it, that just means that we need a secondary solution that we need to design and deploy at the same time as our primary solution. I can give you an example. The Change Healthcare breach recently impacted, a massive swath of the U.S. healthcare system. But the people who are in the front of the line to get resolution on that challenge were the people who were the executive clients, the people who are the large hospital systems, the people who already had a chief information security officer, the people who knew what the impact would be and how to reach out and how to get an answer. And so health centers are by definition at the end of that line because they don't have those things. And an equity first approach would say, okay, let's take all of these people out of this line and give them their own line and their own resources. And let's be proactive and reach out to those people instead of waiting for them to come to us. I think that that's a missing piece in a lot of programs, systems, products. You can go down the list. Healthcare itself tends to leave that to last. And if we want to actually close gaps in health disparities and improve health equity, we have to take those people and populations and move them to the front. We have to talk about them in the very first conversation, and we need to get them in the very first meeting.
We hope today's discussion has sparked your interest and curiosity in the transformative power of digital health. Remember, the conversation doesn't have to end here. You can continue to engage, learn, and discuss by following Health Data Movers on LinkedIn. HDM makes it possible for us to bring these vital conversations to you. If you're looking for solutions that marry workflows and technology, or have questions about today's topics, don't hesitate to reach out at solutions@healthdatamovers.com. Whether you're part of the healthcare industry or simply passionate about the intersection of technology and health, Health Data Movers empowers patients and providers by unleashing the potential of healthcare data and technology.